Dr. Dursa is a PhD. She's the senior epidemiologist at the Veterans Health Administration's Post-Deployment Epidemiology Health Service. She helps design studies to examine the relationship between deployment and health outcomes in veterans. I know a lot of you are going to be interested in what she has to say. She serves as a principal or co-investigator on a number of studies, including follow-up study of a national cohort of Gulf War and Gulf-era veterans, and the National Health Study of a new generation of veterans. So if you would, please join me in welcoming Dr. Erin Dursa to this study.
Okay, thank you. I'm very excited to be here today. So soon after the 1990-1991 Gulf War, veterans began to report a variety of symptoms and illnesses. And so both VA and DoD set up registries in order to sort of capture what was going on. And both registries had the same symptoms that were reported. So things like fatigue, joint pain, headache, memory loss, difficulty concentrating, almost identical in both the DoD and VA populations. But there's limitations of registries, and this is where epidemiology comes in. So registries are typically a self-selected population, and so if only the sick people came in and enrolled in the registry, you would look at your results and you would say, wow, 100% of our registry participants have X, Y, and Z. But we need to know how many people who aren't in the registry, or maybe what the baseline prevalence is in the non-deployed population to really be able to make comparisons. So we need a control group. And so a group from NIH had recommended that there needed to be more population-based epi-studies to get a better estimate of what these symptom profiles were in both deployed and non-deployed to really get a handle on what the excess risk was. And so this is where epidemiology comes in. And for people, next slide please, who may not be familiar with epidemiology, I like to think of it as person, place, and time. So who is sick, when did they get sick, and where were they when they got sick, or the who, the what, and the where. So epidemiologists kind of study the distribution and the determinants of disease in a large population. Next slide. So, and I'm going to go in chronological order of when studies were conducted, not when they were published. So let's focus on, these are the references in case you want to pull the papers, but the parentheses, that's when the studies, when the data collection began. So the first major study on Gulf War illness was actually conducted by the Centers for Disease Control and Prevention in 1994. The Secretary of DoD and the Secretary of VA actually asked the CDC to go out to Pennsylvania to investigate an outbreak of a mystery illness. This mystery illness was Gulf War illness. So it was a cross-sectional study of 4 Air Force units. The index unit in Pennsylvania, which was the unit that was very ill, and then 3 other comparison units. So again, it's this comparison that's important. So there was another air unit in Pennsylvania with similar demographics, but they did a different mission. And then there were 2 reserve units and active duty units in Florida that had the same primary mission as the index unit. So this included a survey and specimen collection. Next slide, please. So this study referred to Gulf War illness as chronic multi-symptom illness. This was their definition that they put forward. And so what they defined as chronic multi-symptom illness, or Gulf War illness, was having 1 or more chronic symptoms from 2 out of 3 categories. So fatigue, mood, cognition, or musculoskeletal. So you need to have 1 or more symptoms from 2 out of 3 categories. So basically 2 symptoms, 1 in each in different categories. Next slide. So using this definition, and again, I think it's important to note that why there's been such a variance in the prevalence of Gulf War illness is that it depends on what definition you use, what population you study, what criteria are applied. So this found a prevalence of 39% in Gulf War deployed, that was mild to moderate, and then 6% for severe, and that was based on subjective severity rating of their symptoms. And in the non-deployed, it was 14% for mild to moderate and 0.7% for severe. And they also did physical and laboratory testing But that didn't identify cases. So there was no, marker or blood test or anything that indicated you were a case. There was also no association with location, time, or duty. They also tried to see if there were factors that may have been related to an exposure. They couldn't find anything like that either. And even though the serological and lab testing didn't identify cases had significantly diminished functioning and well-being. Next slide. So the next study is the Iowa Persian Gulf study, which we talked about a little bit earlier. So this was a population-based study of military personnel from Iowa that included active duty, reserve, and National Guard. And it was stratified by age, sex, race, rank, and service branch. And this is important because when you have a stratified population-based sample, you are actually getting a reflective population of the larger population. So those estimates, it's easier to extrapolate those estimates and to the larger population. So this was a telephone interview of symptoms, medical illnesses, and psychiatric conditions. Next slide, please. So the deployed Persian Gulf veterans reported significantly higher prevalence of symptoms of depression, chronic fatigue, cognitive dysfunction, bronchitis, asthma, fibromyalgia, anxiety, sexual discomfort. A second study showing that deployed Gulf War veterans much sicker than non-deployed era veterans. So the next study that was done was one that the VA sponsored. It was the National Health Study of Gulf War veterans and their families. And this was a cross-sectional population-based study of 15,000 Gulf War deployed and 15,000 Gulf era non-deployed veterans across the United States. And this study was very interesting because it sampled those 30,000 from the entire known population of Gulf War veterans. So it's a truly population-based study. Next slide, please. It used mail and computer-assisted telephone interview to collect the data. There were questions about deployment exposures, functioning, general health symptoms, diagnosed medical conditions, and Gulf War veterans reported significantly higher prevalence of functional impairment, healthcare utilization, symptoms, medical conditions, including things like arthritis, bronchitis, hypertension, gastritis, dermatitis, and then symptoms, headache, pain, difficulty concentrating, memory loss, blurred vision, difficulty with speech, coughing, wheezing. So a variety of symptoms as well as diagnoses. Next, please. Next was the Kansas study. So this was another population-based study of Gulf War veterans and Gulf era veterans living in Kansas. And the primary objective of this study was to define Gulf War illness. So, up until this time, there was no sort of agreed upon name. Was it Gulf War illnss? Was it chronic multi-symptom illness? So Dr. Steele was sort of the first to really try to characterize and define exactly what this was by both person, time, and place. So she performed a telephone interview, asked about medical and psychiatric conditions, symptoms, deployment exposures, and then also the location of the deployment, the time of the deployment, and the unit, getting into that whole person, place, and time thing. So what she found is what really distinguished the Gulf War veterans from the Gulf era veterans, next slide please, were these different domains. So she defined Gulf War illness as having chronic symptoms in 3 of the 6 following domains. So this is a much more specific definition than the earlier CDC. So now there are things like fatigue, pain, neurologic cognition and mood, gastrointestinal, respiratory, and skin. So in order to meet the criteria for Gulf War illness using this definition, you have to have at least 1 chronic symptom in at least 3 of the domains. It must have been recurring and persistent in the last year, and it had to have started either during or after the Gulf War. Additionally, there's exclusion criteria to this study. So individuals who had cancer, diabetes, heart disease, chronic infectious disease, MS were not, they would be excluded because those are conditions that could cause similar types of symptoms. So what she found is using this definition 34% of Gulf War veterans met the case criteria, and 12% of Gulf era veterans who reported receiving vaccines during the war, and 4% of Gulf era veterans who did not receive vaccines during the war met the criteria. I know during this time there was a lot of concern about the vaccines and the squalene and whether or not that was behind, Gulf War illness. So another interesting part of finding from this study is that she found out that among the Gulf War veterans, the highest prevalence was among those who were in Iraq and Kuwait, and the lowest was among those who served on a ship. And the highest prevalence was among those who departed in June of July of 1991. So, I think that's a lot of the cleanup missions, Camisea, a lot of the heavy duty exposures were thought to have occurred after the war ended, between February and June of 1991. Next slide, please. So the next study is the CB Health study. So the Navy Seabees, who are the kind of mobile construction battalions, were one of the most symptomatic groups of veterans coming home from the Gulf, and especially those who were in a specific unit from Southeast United States. So that's the who, the what, and the where. So DMDC, which is sort of DoD's data repository, provided a list of all CVs assigned to the CV units during the time of the Gulf War, and all of them were invited to be part of the study. Next slide, please. So of those 17,000, almost 12,000 responded. And so they really, again, got a whole picture of the CV population. So it was a postal survey. They used many of the same questions from the VA study. And they also looked at deployment exposures, family history, symptoms, and health history. So as in the other studies, the Gulf War CVs reported poor general health, please, a higher prevalence of all 33 medical conditions that were asked, and higher prevalence of cognition difficulties. They also had a higher prevalence of 4 multi-symptom conditions: chronic fatigue syndrome, PTSD, multiple chemical sensitivity, and irritable bowel syndrome. So the working case definition for the CB Health study, they had done some factor analyses, and it seemed that these 4 cluster diseases clustered together. So that was sort of their working definition for Gulf War illness. And then 12 of the 34 Gulf War exposures that they collected information on were moderately associated with Gulf War illness. And exposure to fumes from munitions had the greatest odds ratio. So that was the one that kind of conferred the most risk. So now we're going to move on to what kind of is going on in the present. And this study, the follow-up study, the National Cohort of Gulf War and Gulf Era Veterans, we began data collection in 2012 through the end of 2014, and this was a 20-year follow-up study of the population that was surveyed in 1995. So it's the largest longitudinal population-based cohort study of Gulf War and Gulf Era veterans to date. So we went back out and we surveyed the same 30,000 who were originally contacted in 1995 to get an update on how they were doing. Next slide. So 20 years after the Gulf War veterans continue to report poor health in Gulf Era veterans. They reported more healthcare utilizations, both doctor visits and hospitalizations, and more likely to screen positive for a mental health condition. They reported significantly higher prevalences of chronic diseases, such as Gulf War illness, COPD, tachycardia, coronary heart disease, hypertension, asthma, neurology, seizures. The list goes on. Basically every question, every health concern that we asked about, the Gulf War veterans had significantly higher reporting of it. Next slide. So 79% of the study population reported at least one chronic medical condition. It was a little bit higher in the Gulf War veterans, 82% in Gulf War veterans, 78% in Gulf Era veterans. 45% of the population, this is the entire study population, that includes deployed and non-deployed. 45% screened positive for a mental health condition, 52% in Gulf War veterans and 39% in Gulf Era veterans. And the average number of self-reported chronic medical conditions was 3.5. So 3.7 in Gulf War, 2.9 in Gulf Era veterans. So that's pretty high. So the next study that our office just recently completed has to do with brain cancer mortality among Army veterans who were at CommSIA. So mortality studies that were done through 2000 and 2004 have shown an increased risk of brain cancer mortality among Gulf War veterans who were potentially exposed to nerve agents and other contaminants at CommSIA in March of 1991. And so when I say mortality through 2000, what we do is we look at cause of death and mortality data through the year 2000, and we look to see among all those who died, who were at CommSIA and who were not, what were the leading causes of death. So in 2000, what we found is that the adjusted risk ratio for Army Gulf War veterans who were possibly exposed to CommSIA or more for CommSIA for 2 or more days, the odds ratio was 3.26. So they were, 3 times more likely to die from brain cancer than Army veterans who were in the Gulf but not exposed to CommSIA. So we ran those analyses in 2004, and we found the same thing. So in 2004, the risk for brain cancer mortality among Army Gulf War veterans was 2.71. So it decreased a little bit, but still significant. So now we wanted to look at date of death through 2011 to see what's happening over time. So this study was to examine brain cancer mortality risk over time between 1991 and 2011 among Gulf War veterans deployed compared to Gulf War era veterans and deployed Army veterans possibly exposed to environmental contaminants and those not exposed to environmental contaminants at CommSIA. This gets like a little bit, can you go back a slide? So there were 3 studies done on brain cancer. One in 2004, one in 2000, one in 2004, and then up through 2011. And each point in time, we were looking at the risk of brain cancer mortality. And so we're looking over time to see the trends that have popped up. So when we look at brain cancer mortality overall between Gulf War and Gulf era, this is not looking at CommSIA. This is taking out people who were at CommSIA and just looking at deployed and non-deployed. There was no difference in brain cancer mortality 20 years after the war. And the 20-year follow-up, U.S. Army veterans exposed to CommSIA had similar rates of brain cancer compared to those not possibly exposed. However, these veterans who were possibly exposed had a significantly higher risk of brain cancer in the period immediately following the war, namely the first 10 years. So a similar pattern that was seen with ALS in Gulf War veterans, where there was a spike and then it kind of dipped off, we're seeing that same pattern with brain cancer mortality. Next slide, please. Okay, so now the future of epidemiologic research. And so it feels only fitting that we would start with genomics because that seems to be the future of everything. So right now, what is in planning and is going to be kicking off soon is the genomics of Gulf War illness in veterans. So this study is to evaluate potential genetic risk factors for Gulf War illness by conducting a genome-wide association study. So this is really fascinating because not everybody who was in the Gulf got Gulf War illness. Not everybody who was exposed to things like PB or pesticides got Gulf War illness. So maybe there is some genetic underpinning that makes someone more susceptible to Gulf War illness when they have a certain exposure. And there has been some work by Dr. Lee Steele that has shown, suggesting that there is a genetic polymorphism that is interacting. So this is part of the VA Cooperative Studies Million Veteran Program. So this is a study that is trying to enroll 1 million veterans. They just met the 500,000 mark to sort of be the largest repository of genetic information, military exposure, lifestyle, and health information. So in order to be part of this study, you have to be in the Million Veteran Program. So this is a case-control study nested in the Million Veteran Program. And so what they're going to do is they're going to compare those with and without Gulf War illness using the MVV chip. Now this is getting a little bit technical here. So it basically contains 246,000 genome-wide association markers, 238,000 exomic markers and insertion deletions, 70,000 loss of function, SNPs, and insertion deletions in various custom markers. So it's going to basically try to find any sort of genetic difference between the two groups. So this next project, which we are going to be kicking off very soon, Dr. Rum alluded to it earlier, is the predictive analytics to refine current case definitions for Gulf War illness. So the lack of unified case definition has really been problematic, I think, for researchers. It's been problematic for clinicians. I think it's been problematic on the benefit side. So the National Academy of Medicine had recommended that VA systematically assess existing data to provide more robust definition. So the goal of this project is to integrate multiple VA data sets in order to develop a data-rich cohort. So we would have information from research studies, we would have information from the registry, we would have information from the VA medical record. And so we would use this multi-system approach to identify those with probable GWI. Now, to get a confirmation, that needs to be determined by a physician. But this is sort of using a statistic and mathematical approach to identify people who are likely cases. And then we would evaluate in a clinical population. So I'm going to try to breeze through this so we have time for questions. But basically the process is that we identify cohorts of veterans with and without indicators of Gulf War illness. So ideally, we would have a diagnosis of Gulf War illness. But as you know, there's no ICD-9 code. We can't just look at the VA medical record and say, okay, pull out everybody with an ICD-9 code for Gulf War illness. So we're going to have to take a couple of different approaches, looking at just deployment status as a marker. We have a couple different techniques for how we're going to do that. But we're going to evaluate all the variables in the electronic medical record for patients in each cohort. And diagnoses, labs, medications, procedures. Next slide, please. We're going to look at exposure variables from the Gulf War Registry and the Gulf War Survey. And then we're going to use machine learning to find variables that are significantly different between the cohorts. So we're letting a machine do all of this. And trust me, we'll get people involved too, but the first pass is you sort of let the statistics decide what is important here and what is not. And then, we'll use random forest and stepwise modeling to identify variables with the strongest association in conjunction with, kind of expert clinicians and epidemiologists to guide that. Because when you have sample sizes this large, you often get associations that have nothing to do with, true relationship. They're just alpha error. So then we'll modify, kind of do all the techniques to perfect the model, look at sensitivity and specificity. And then we would test in a clinical population, probably a population where we know there's a lot of Gulf War illness. And my ultimate goal, this is a project that I'm heading, my ultimate goal is to be able to develop an algorithm that will run on the VA medical record that will flag patients that are likely cases of Gulf War illness, that they could be flagged and then sent for a higher eval. So it would take, we do know that education of providers is one of the larger problems that VA has with Gulf War illness. So this would be sort of taking it out of their hands and having the algorithm run, and then it would automatically flag patients who are likely cases but still need to be evaluated by a clinician. So some additional studies that are funded and will start in the next fiscal year are longitudinal assessment of Gulf War veterans with suspected sarin exposure, vascular and skeletal muscle function in Gulf War veterans illness, identifications of plasma biomarkers of Gulf War illness using omic technology, diagnostic utility of mitochondrial DNA content and exercise challenge in veterans with Gulf War illness, examination of cognitive fatigue in Gulf War illness using fMRI, and somatic hypersensitivity in veterans with IBS. So this is all VA-funded research, and it focuses, solely on the symptoms and conditions that
are getting sick. And
Well-
my spouse had several issues that I had, and he's dead now.
Mhm.
Okay, so there is, and also I want to comment on the medical records, that through the years, the doctors don't have time in 20 minutes to sit down and listen to the Gulf War vet. They have their ABCs they have to go through, and whenever time's up, it's up. So the real issues of what we're dealing with do not get in the medical records all the time, and if not, they may not be accurate, or they may be left out. That's an issue when they keep talking about going back to the medical records.
Right, so they're actually, the VA did do a study, I want to say it was in 2000, it was Cooperative Studies 458, and it enrolled Gulf War veterans who were enrolled in our large population-based study, and it also enrolled their children and their spouses. And they did publish a couple papers, I can look for them, because I think this was at the time when there was concern that it was some sort of infectious agent. So they are currently, they never did anything on birth defects, but I know that they're in the process of looking at that data because there's an upcoming IOM report on birth defects. But in terms of spouses, and again, these are people who enrolled into a study, so this may be a little bit biased, but they didn't find anything significant in the spouses. But, that's, again, if, there's reports of this kind of stuff, but in the published literature, and again, I'm here to talk about the published literature, I haven't seen anything sort of indicating an infectious agent. But I think that's something that it is important to bring up with your clinician when you see them.
When we got those questionnaires, and a lot of us got them, and we looked at it, and it was heavy into stress. And a lot of us said, no, we're not filling this out. And so you missed in the first go-around, because we saw the focus on stress.
Is this the
And
1995 study?
Oh, way back at the
There
beginning,
was
when
an
they first sent
there was an
out.
80% response rate on that.
I know, but you missed about 20% at least that got them. I got one, and I reviewed the questionnaire, and having a master's degree, I felt it was slanted to stress.
Yep.
I chose not to participate. A lot of others did not. So, I've been bringing this up. It's not possible now, I guess, but to go back and try to pick up the ones you missed, with a new survey. Because we do hear about the spouses. We had a registry for a while that the spouses could be registered in, any child. But it was a law, but it ran out of time, and we didn't get it extended. So there was a lot of data that could have been collected that weren't. And there's legitimate questions that we all hear all the time, and you can't just wipe it away. And I keep up with all the research and read it all, but I think that was part of the problem in getting more data and the power of that data. So I just wanted to bring that up. And any other vet that got that survey and looked at it and decided not to opt
I
in?
concur. I threw mine away.
Yeah. You got it and threw it away. Raise your
I
hand.
got it. It's stress. It focused on stress, and I threw it right in the trash.
Okay?
This was the
You
one,
need to-
this was the, which study, the
That started
1995?
in
Yep.
1995.
Yep.
The question I got for you on that there on 95 is, y'all stats up there, y'all stats is on a low-risk unit. Y'all stats ain't on a high-risk unit. A high-risk unit mean a combat infantry unit on the front line. Those are low-risk units that I see you got up there, because there wasn't no infantry unit in Florida. And the second question I got is, the people like me, and when Desert Storm was over with, turned around and had to go to Boston. Soon as 95 over with, the only reason why I came back to the United States is because my grandmother and my mother passed away, and right when I hit 95, September 95, November 95, I was back in transit actually in Kuwait. So how do y'all get data on people like us Task Force 141 and the high-risk infantry got hit, and your stats come out, you know, with a mediocre stat.
None of these stats are really mediocre. I mean, every study that has been published has shown significantly higher.
You saying, Iowa, Kansas, Fort Riley, Kansas, Big Red 1. Big Red 1 didn't come over there till after we was over there in the league, because I was the front line for first ID. Big Red 1, I was second AD forward. I got hit by the friendly enemy fire. Okay, I was in the unit that got hit by the Hellfire missile. Tom Miller got hit. Task Force 141. So I'm looking at your stats. That half of the guys, I got a guy over in Orlando right now, they just sit up there and holler that he got canceled when he got hit by DPIC, depleted uranium. You know? And we all trying to keep in touch to find out who all passing away.
Right, yeah, so I think that's one of the challenges when we talk about population-based. Can I answer your first question first about the different?
I'm gonna cut off, but VA saying that, okay, you ain't high risk enough, but you get a Purple Heart, but you ain't high risk to get a disability. We don't look at you as a priority.
So the benefits, VBA, I do not know what goes on there. I'm glad I don't. I hear very, very bad things from veterans who are dealing with them. But, you know, one of the challenges in population-based research and in epidemiological research is that we were trying to get estimates for the entire Gulf War deployed population. And you are absolutely right. Within this large group of 690,000 personnel who deployed, there are probably certain units and certain groups who were way more at risk because of the job they did, because of where they were located. And so a lot of that unit information, that's not sent directly to VA. So, you know, when we get our information, you know, we get the branch of service, we get the age, we get the date, we get those sorts of things. And so we don't typically do analyses by specific subgroup or unit other than CommSIA, because that data is available. You know, DoD will provide the list of veterans who were at CommSIA. So we can do subgroup analyses of those high-risk people at CommSIA, but, you know, other units who may have been, you know, doing cleanup or, you know, the ordnance guys, we don't have that level of detail. So yes, I agree with you that there are probably certain units who had way more exposures than another unit, but when you look at the large population-based studies, it's taken into account everybody. So the high-risk people can sometimes get washed out because you're with the larger population. And those are what population-based studies do. Yes?
And the last, on the back end of it, because I seen when you said that a lot of people that came down with some symptoms was from February 91 to June 91 that stayed over there a little bit longer. How about a person like me that stayed over there from the day it kicked off all the way to August 1991? And I ain't know, I'm this first time I'm hearing about it.
Right, so, you know, again, we do know that the oil well fires were burning into, you know, 1992, so there was still smoke, there was still...
I was definitely, that's what I said to the first doctor that was up there. I was the unit that went through the oil field where everything was black. There wasn't no daylight.
Right.
We was oil. Everybody was the same. We had to get sprayed down with high pressure hoses to get cleaned up.
Right. No, and we know that there are absolute toxic health effects of oil, smoke, and oil products. So I think that, you know, this idea of defining an exposure period, I know there is sort of scientific opinions, difference of scientific opinion on, you know, the VA studies. You know, when we drew the sample, we used the end date as the end of the actual war. And so, you know, and a lot of people say, well, the most toxic exposures happened after the war. You know, it wasn't until a couple of years after that they even acknowledged CommSIA. So I think that, you know, there were a lot of things happening where we became aware of these issues. Oh, CommSIA, oh, these oil files. And so that's why we did those analyses looking at the Comessia group. But yes, I agree, and I think it's really hard to pinpoint, when was somebody at risk and when did they become not at risk, right? Because when you're in an environment where there is smoke and where there are fumes, that stuff can linger. So I think that that's a very good question. I'm not sure that any of us could ever answer it, especially, looking at this happened 20 years ago. But, I would strongly suggest our website and the risk website has, because I know that VA providers sometimes are not up to date on any of this. You need to go to the risk website and the post-deployment health website and pull all the information about what is considered presumed for Gulf War service and the other conditions. And, you could direct your primary care providers to those websites as well.
I have two questions. Regarding what the first one regarding what you just said. As VA providers, our only group of people that we serve are veterans. So how is it that a provider does not know this stuff? Because that's the only population that we deal with. We don't deal with their families, we don't deal with their children. We take care of vets, and mostly combat vets. And we're now starting to take care of our generation, Persian Gulf War generation. We're taking care of the Afghan, Iraq War veterans too, that are coming, these kids that are coming back. Still have Vietnam veterans that are just now being, compensated for their Agent Orange, which has affected their hearts. So how is it that we, as most people are not even medical people. I happen to be a registered nurse. I work in the cardiac cath lab. The providers, I would think, are the ones that should be aware of all of this information, not the patients that are coming to the providers, because that's our population.
So I'm going to sort of give a neutral answer on that, because I know that there are training requirements for physicians. Again, that's sort of outside my realm. However, we have TMS trainings on this. We have risk webinars. They are available, and that's why I suggest going to our website. Jim has you've worked on some of the trainings, the clinical practice guidelines. So I think that they're there, but the actual dissemination of the materials probably is subpar. So they're there. And so if they, and we talk about, I don't work in education, but I know the group in our office that deals with education is like, well, can we enforce that people take, because there's all these mandatory things that VA clinicians have to do, right? Like the hypertension metrics. It's like one more thing that they have to add on, and I think that providers, a lot of times, they're so busy with getting what they have to get done that adding on another set of trainings that, they may not do it, but they are there. And so, in terms of enforcing it and making sure that, primary care providers who are treating Gulf War veterans have to be aware that if they're showing up and they have these symptoms, you may have Gulf War illness, we need to get you in to see, a risk doctor or go to specialty care. We do have, we have an exposure handbook, we have all sorts of materials that, we can either send to the medical center or you can download them online and photocopy them, because we have them. And, we work with a lot of veterans to actually make them, attractive to both veterans and providers.
A lot of it keeps changing, especially within, I'd say, the last maybe 5-6 years. And the Risk Center, WRIISC, the Risk Center is your greatest tool that you can get a hold of for help, are their websites. There's a portion for providers on that. That's your greatest tool, because the education portion of it is not mandatory. But this is to hear, they're here helping you out and that, and she's not going to be able to answer questions about your care for veterans and what's going wrong with the claims and all that. But this is here to really help out the providers this morning. So there's a good Q&A session this afternoon for the lot of you veterans.
Now, on that note, one of the things, I've been preaching is the establishment of centers of excellence. Basically, we don't expect, we know, okay, trying to get all the teachers, all the doctors, all the nurses educated on GWI is impossible. That's common sense. You can't, it's not going to happen. But if we could have at least one physician, one single physician within a region, so that if a veteran goes to a clinic or whatever, like, okay, you're GWI vet, oh, you served during this time frame, guess what? We have a specialist in that area, go see him or her, then we have something. But right now, you take, for example, it was about four months ago, I ended up going to the emergency room at the Muskogee VA, right? Because I was having an episode. Well, guess what? After they ran all the tests and this and that and whatever, they couldn't find anything. Everything came back normal, as usual. I'm used to that.
Glenn,
But-
that was a recommendation that the RAC we submitted to the secretary for.
Well, the thing though is, when I went to the emergency ER, the physician at the ER has the nerve to tell me, one, there's no such thing as GoFundMe, and two, I'm submitting a request for a side valve. I laughed in his face. I said, I'm going to educate you. I will forgive your statement because it's done out of ignorance. But when it comes to GWI, it's sad that I know more in the entire, you take the entire state of Oklahoma, I know more when it comes to the law and the medicine, the publication, the research, than all these doctors within the VA system in the entire state. And that shouldn't happen. We
Congress
should,
is not allocating the funding, basically,
yeah.
to train people that are actually interfacing with those vets.
So I do know that the risk, and this is sort of, maybe a short-term solution. So the risk will do teleconsults. So, and the risk, the veterans say nothing but wonderful things about the risks. They're,
Yeah.
managing, I don't know if you've been to one, but with managing the disease and, managing sort of the comorbidities. So they can do e-consults as well as telephone calls. I think they're also set up for VTEL. So, that, and believe me, I understand it. I'm not a provider, but I hear all the time that there are providers at the VA that says this is not real, and so I could completely understand your frustration, but I said, I think I did hear at the RAC meeting that's going to be a recommendation.
It's already is.
Right, and whether we can do like mini residency programs where, we have, the environmental health clinician. Every VA medical center is supposed to have an environmental health clinician, and that person, I think, should act as sort of the middle person between the veteran and then maybe the experts at the risk, where, they should be the ones recognizing the issues, and then if they can't address them, they should, talk to the risk. But the RAC is usually very, very good at getting this stuff to the secretary, so stay tuned. Who else?
Hi, how are you?
Good, how are you?
Sean Scott. Just want to make a quick comment. As far as all those surveys go, there is a much larger audience out there that's not getting touched. I myself was giving orders while I was over in theater to be assigned to another unit. The problem was those orders never made it back to the DOD. So when I tried getting help from the VA, I was told, you're all the way in South Saudi Arabia. If I didn't have a copy of those original orders, I would have had a lot of problems. Those orders were destroyed. I've got a lot of people that know this, but a lot of records below brigade level were ordered destroyed and never made it back to the United States. So thank God I kept a copy of those orders because I was able to present that. Those orders, I guess there was a study that was done about all the exposure to the oil fires. I originally went onto that website, put in my social security number, and it said, hey, Mr. Scott, you were exposed for 6 days. I said, that's not right. I took a copy of those orders and I got a hold of the person in charge of that study. I mailed my orders to them and they recalculated and they said, oh, 39 days. I was within 5 kilometers of Commissary when I was detonated. As a military policeman, I actually helped secure that area. So I was there, so I actually consider myself a Commissary survivor. I came to the VA and I went to my primary care and I walked the whole gamut of going to every discipline here at the VA. Phenomenal staff. I have no complaints whatsoever with Tampa VA. They've been amazing for me. My primary care provider put in a referral for me to go to risk. And it took quite a few months for that to happen. We got a reply back from Dr. Reinhardt, I believe it is, who said I was getting great care at the Tampa VA and there's no reason for me to go to risk. But here's my problem. I've had issues with the Tampa VA and their lack of education in Gulf War illness. I don't want to say it in a negative light. So I still want to go to risk. I've been to Georgetown University with Dr. B, phenomenal staff there. I've been down to Miami. I try to get into all the studies I can. But it's my understanding that I've talked to other Gulf War veterans, the great help that they got after going to risk and doing studies and doing tests and coming up with treatment plans. How can I still try to get into that for helping me? How can I try to get back into the risk program? I hear other Gulf War veterans going, and I want to go. Who do I contact now at this time?
So I believe you still have to, I believe they have to put an order in CPRS.
Yeah, your primary care
Yeah.
needs to just say, I disagree, and put the order back in.
I have a new primary care
Yeah,
now, so.
I just reconsult and and say that the veteran is very keen to come to your program, and we'd like to appeal your earlier decision or something, and then put some medical reason.
All right, so I still have to continue pressuring my new primary care for that?
There has to be a consult, or they don't know you exist, so you have to throw a consult
What
in.
is the consult? I work in PAC with 6 providers, and I'm sure none of them know or, I've never seen a consult place in my clinic.
Do you want to make
So if you were to look as a provider under consults, the very last thing of all the sections, the non-VA care, blah, 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 there's someone that says WRII risk, SC, right? So when you click that, it says war-related injuries, but it's the abbreviation, WRII-SC. And it's just like a regular consult, you put it in, but it's an electronic consult. And they review it and decide if they can take care of you through telehealth, or if they need to see you in person.
Okay, because I'm just a PAC RN, and I've had a doctor ask me what is palliative care before, and I didn't know hospice nursing. So I want to know what this is, because I've had patients be very frustrated that they didn't feel like they were getting the care they needed. That's why I came to this today, and so I'll share it with the providers if we're.
So my advice, even though I'm not a risk doctor, I'm the University of Miami's Gulf War doctor, is that if you're going to put in a risk consult, and it comes back as a telehealth, organize the telehealth to be with the provider and the patient at the same time, not just with the patient alone. Because then everybody's on the same page, you work through a plan, you can come back again in 6 months or a year and make sure you've ticked all the right marks and you're doing everything right. So you can use the risk as an over-the-shoulder doctor in the room to help you with that.
And there's a stack of Gulf War newsletters on that table. There is a section in the Gulf War newsletter there's information about the risks, current studies that are enrolling for Gulf War veterans. So grab a couple of those and maybe take them back we brought a lot so that you could take them back to your clinic and make them available to veterans. Because like I said, we have all these resources, but I think a lot of times, both providers and patients don't know that they're available. But that has a lot of information about the risk.
So I think we're right up against lunchtime. I saw one question in the middle there in the back, and then yes, that'll be the last question for this session. Good. In the middle, the back there. Yes, red hair, yes, you.
I was wondering, are our medical records anyway annotated that we were deployed for Desert Storm? Because over the years, I've had different providers be totally.
Sure. So that's actually one of, that's actually a very, well, so there is no flag, and I know this has come up several times, there is no flag in the VA medical record for Gulf War deployment. And what happens is, my understanding has to do with the way that Congress wrote the law, and Jim can probably, that the 1991 Gulf War never technically ended, and it's lumped in with OAFEIF.
Mm-hmm.
So Gulf War service encompasses 1990, 1991 Gulf War. moving forward all the way until the present time. So there is no indicator in the VA medical record that says, you know, you're a Gulf War veteran. So, you know, that, and, you know, I guess there's ways, you know, you tell your provider, but I don't think your provider, there's no way for him or her to look in the medical record and see. So they would, you know, you would have to provide them that information, because I think it's more of a global, you know, Gulf service.
Gulf War era.
Gulf War era, which is 1990 all the way to the present.
So it's 11:30. We'll have time this afternoon for more questions. I want to thank Dr. Dursa for coming, for giving us the time. As a frontline provider, I can tell you that the epidemiologic research that she and her team are conducting is so important for us to know associations, odds ratios, hazards ratios, with the questions we ask, the tests that we order. It's been so important through the years with Agent Orange, Hep C risk, so many other things, and now continuing on with Gulf War exposure.